Thank you. Morning, everyone, and it's a pleasure being here in Chennai again. So, I did miss part of the other two conversations, which would have liked to listen on the in-hospital management. I'm going to stick specifically to the perioperative part. Some amount of it is evidence that is published. Some amount of it is experience sharing with some caveats. So, let's make this interactive. I would also say that the discussion I'm having is from 2 points. This is the RSSDI in-hospital guidelines that we published in 2016, which hopefully in the coming year we'll update, and certain slides that Dr. G. Vijayakumar was kind enough to share with me, which were his thoughts on in-hospital management. So, perioperative management is perioperative management is what I'm speaking about. So when you talk about diabetes and surgery, well, there are three important aspects amongst many others. One is the stress which comes in from being in a hospital or a surgical stress. The anesthesia itself, which adds to the stress and the possibility of infection. So let's understand that, like many other situations, surgery is diabetogenic, if there is any word like that, but it is something which can push up the sugars. Again, when we see who's at play here in this perioperative time, it's the diabetologist, which sometimes gets asked to control before the surgery. Very often nowadays you are involved after the surgery is done. So it shouldn't be the case, but that's how it is. I don't know, any surgeons in the house? Good, so I can speak my mind. So then you have the physician or diabetologist, endocrinologist, you have the surgeon. And then what actually is missing in most setups is a diabetes specialist nurse who can actually play a huge role in ensuring the entire hospital stay and perioperative period goes smooth. So success of surgery depends on the close working of the team together. Each one achieves more is the motto. This is GVK's motto, and I'm happy to follow that routinely. Now, surgery in diabetes, the determinants of the management plan, of course, depends on type 1 or type 2. So we heard the previous conversation, even Dr. Mohan speaking about type 1. So type 1 becomes a special scenario which requires a little more specific care. It also depends on what treatment was the patient on. Was the patient only controlled on diet? Was he or she on OHAs or was already on insulin? What is the overall metabolic status will play a role on the surgical clearance, or in case of emergency surgeries, what to expect. The vascular status, which means you're talking about comorbid conditions in the perioperative period, patient's overall cardiac fitness, renal parameters, any history of previous CVAs, etc. The nature of the surgery itself, right? So what kind of surgery are we doing? Are we doing a minor surgery? We are doing a major or a supra-major surgery? Everything will, a lot will depend on that. And whether the surgery is elective or emergency. So again, that changes the scenario, and I'll be moving specifically to how we can go about it in these scenarios, and the kind of anesthesia which is being used, whether it's again local, spinal, general, and so on, and the post-operative oral intake that your patient is anticipated to have. Now, when we talk about the chances of infection, well, it's always there. Sometimes you will have a patient with uncontrolled hyperglycemia landing up with infection and then requiring a surgery like debridement or so on. So trivial injury can lead to cellulitis, not taken care can turn gangrenous. There's a rapid course of the foot infection. Within 2 to 3 days, the whole scenario can change. The question often asked is what to do first, right? Do we wait to control the sugars or we do the surgery first? Right. What do you think we should do? It's a general open question. Right? Surgery. Does anybody think any other way and not, sorry? Simultaneously. Okay, good. Anybody wants to control the sugars first before the surgery? Yes, I can see a couple of hands, yes. Right? So if it's emergency, then you're going to go ahead and do it. If it's elective, if it's your cataract surgery or other things, there is no rush. You will wait and control sugar, right? If there is of course, a gangrenous foot, a burst appendix, acute cholecystitis, which is turning gangrenous, and so on, you don't have an option, so you'll do that. Yes, so the fact is that, let's say the commonest thing that most of us may come across is a bad infected foot wound. Right? The sugar is 250. and you've controlled for a day, day and a half in the hospital. You've managed with basal bolus insulin where required. You have used intravenous, and on the morning of the surgery, in spite of all your calculations, the fasting sugar comes as sorry 265, and the RMO from the hospital tells 265. The anesthetist is now worried about taking up for the surgery. What will you tell them? Should they go ahead or they shouldn't go ahead? Right? This is for a debridement, SOS, certain amputation of the leg. It's a bad gangrenous foot. The morning sugar for the surgery is right. Exactly right. So we know that this is pushed up by the sepsis there. The moment you drain the cause of it, the sugars will fall down. Right? So there is no real worry about the sugars being there. Yes, on the day of a cataract surgery, if the sugar is 250, you may want to hold that back. But the ophthals are smart enough; they don't ask you to check the sugar on the day of the surgery. They'll take a clearance a week before, and which is fair enough. So, also, what we understand is the concept of HbA1c, which for many others in the surgical line, they're not so well apt with that. So they will look at individual sugars. Right? Your patient has, now let's say for cataract, and I'm deviating from the slides here. Your patient's HbA1c is 7.8. The sugar a week back when the patient saw you was 135 fasting, 178 postprandial, and an A1C of 7.8. And you've given clearance for the surgery, right? A week later, so again, this is your clearance. Then the patient will go to the ophthal. Ophthal will now say, do all these tests, your HIV, blah, 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 urine routine, and again a fasting PP. And the fasting PP done that day came as 154 and 204. Right? Does the patient go ahead with the surgery? Does the ophthal take up the patient or no? Right. So that's what we know, right? The ophthal will see the numbers and say, no, go back to your physician, diabetologist, get the clearance done and come. Right? And the patient comes to you next day, urgent appointment, my surgery is not happening. What will you do? So that is theoretical. I'm still asking you, this is the situation in your clinic. Your patient whom you have given a clearance a week back comes to you, right? You've given the clearance because the fresh pre-ops have shown a 154 and a 204. The HbA1c 6 days back was 7.8 and you had given the clearance. Stable, you're doing a cataract surgery. So will you want to, yes sir. So it's a elective surgery is what the doctor they're saying, you can control it and then call that. Okay. Are there chances that when you postpone this surgery and this patient who's been query struggling for sugar control comes to you a month later with an HbA1c of 8.4 and sugars of 170 and 240? Right. So, yes. Right. So, yeah, these are not, so these are not made up situations. This is real life situation that you and me face in our clinics every day. The fact is that today an 8% HbA1c is an acceptable range for an elective clean surgery. As I said, if it was an emergency surgery, you would not care about what the HbA1c is and you would do that. So at this point in time, what would be right is picking up your phone, calling up your ophthal colleague and saying, look here, the A1C was 7.8, the sugars are 145 or whatever, 154 and 204, which were normal earlier. I believe this patient is good for the surgery, though at this point I'm mildly up titrating whatever therapy, be it OH or insulin, because yes, I would like to get this patient down closer to 7 eventually and the sugars are high. But if you have planned for surgery 2 days from now, you can very well go ahead with it. Right? Of course. So do you really need to monitor aggressively around a clean surgery? Maybe not. So let's also understand that we can be as ideal and theoretical as we would like to be. But one thing that we very often forget as clinicians and doctors is that are we causing distress to our patients in any kind? And diabetes in general is a huge impact, has a huge impact for any kind of diabetes distress. So let's understand, we treat with human beings, we are not just treating with a condition or disease. Something with this may come with years of experience that many of you have, is that nothing will happen predominantly. So you can do that, but anything which is going to distress the patient, then it doesn't make sense. Well, the other situation would be the patient is coming to you with the sugars of 170 and 220 with an A1C of 8.4 and said that I had planned for surgery. Next month is my daughter's wedding, and then we are traveling, but I needed to do the surgery next week. Then what will you say? So then don't bother about the diabetes distress. If it's not under control, it's not under control, right? So you will see the situations. Very often patients will push you for aspects of social and planned needs. If it's not under control, for a clean surgery there. So my point largely was A1C is a pretty decent indicator there of overall control, and you can take a call on that. Your 1 day's fasting postprandial shouldn't change things much. So there are going to be certain infections which are ketogenic in nature, and you will see that again. Typically your carbuncles, right? The patient, type 2 patient, okay, till a week back, carbuncle developed, tried to apply some ointment, blah, 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 it has increased. And now the sugars are 350, 400. And in the hospital pre-op, you will start getting ketones. This is known to happen. So just control with fluids and insulin there, and your patient will, the ketones will disappear within 24 hours before the surgery itself. Request to anesthetist. Now, any anesthetist in the house here? Okay, one. So, sorry, you know. Okay, so this is a request to the community, which most of the time it happens. So on paper, this is always there, but you see, surgery preferably in the morning. We are aware that a lot of anesthetic drugs today may increase the blood sugar, though the newer ones are not as diabetogenic. Surgical stress itself, so any kind of surgery is stress for the body, it will cause increase in sugars. Your preferred fluids are 5% IV dextrose with insulin, again depending on what the preoperative sugar levels are. You can of course monitor the sugars today by doing regular SMBG. In many hospitals and situations, CGM is being used now continuously, though not officially approved for in-hospital use. There is a lot of off-label use of CGMs today around the perioperative period, and I think it's a super means of keeping a track in the direction in which the sugar is being used. Yeah, so I go back to the first point, preferably in the morning. Sir, you are the lone anesthetist in the house. Do you get this request? Right? So, and do you all comply? Or it depends on which surgeon is the king of that hospital and who gets the right to the OT in the morning and the others don't. So again, that's ideal, right? I'm a top-notch surgeon. I do the best of cases in this hospital. My time is more important, right? A mid-level consultant has put up a case, right? And in that case, he would have ideally liked to do at 7:38 in the morning, but the first 3 cases are booked for me because I do TKRs and I bring about more money to the hospital. What happens then? Right. So there will always be a request, but as you said, you will try and comply, but sometimes it may not happen, and you may have very often the diabetic individual undergoing surgery at 3 in the afternoon or 2 in the afternoon. Right? So you will put them on IV fluids and manage. Yes. So you will see all recommendations, all slides, all papers are in hospital. This line will be there, that surgery to be earlier in the morning or amongst the first cases. It's not practical. Where I worked for over 10 years at Asian Heart Institute in Mumbai, which did at 1.6 to 7 CABGs. Out of those 6-7 CABGs, 4 would be patients with diabetes. So it's not possible to have every patient as the first case in the morning. Very often that individual would be kept NBM and would be taken up only at 4. Into the OT, the case would start at 7 in the evening and finish at whatever time. So it's good to put this line up, but it doesn't happen. So we as physicians, diabetics, should be prepared to work around with the fluids and glucose in that prolonged NBM period. Well, there may be certain circumstances like type 1s, etc., where you would really want to push it. But for many others, given the practical situation, this may not be possible or warranted. So request to anesthetists, kindly consider fitness for surgery when blood sugars are less than 200. Use short-acting human insulin if the sugars are more than 200. Fasting may have increased due to hepatic glucose output, especially again surgery. Stress itself can bring about increased HGO, and on the day of the surgery, as mentioned earlier, you may have a situation with high sugars. Use the glucose insulin drips and handle that. Also, on the previous day, for patients who are already on insulin, do not skip dosages of your basal insulins or intermediate acting insulins. Right? So, very often we see this kind of a mistake, if I can say, called patient is already on insulin, and because the instruction is patient to be kept nil by mouth after 12 in the night, on the previous day, you would give only the short acting insulin dose there and avoid the long acting insulin if the patient was on. Well, that most certainly will push your patient in the morning of the surgery as 200 and 250. You may want to cut down the dose by 20-25%, but use the basal insulin if the patient is already on there. In fact, if the patient was not on insulin, was on OHA, and you were admitted and you wanted to up titrate the control before surgery, a basal insulin would be actually a best means of controlling in the subcutaneous form. Proper pre-op evaluation, evaluate diabetes complications which may influence anesthesia. So of course you're looking at cardiac and renal parameters. Change from OHA to insulin and its requirement need to be determined for at least for major surgeries. You will try and stop the OHA a day before, metformin on paper 48 hours before. But again, if the patient's renal and cardiac parameters are fine, you may not have to stop it 48 hours before. You may just stop it a day before. I now move to using the certain specifics from the RSSDI and hospital guidelines on the procedure. So minor procedures, it's coming down to specifics who do not require overnight hospital stay, getting admitted next day for minor daycare procedures, and a lot of procedures today happen in that manner. Anticipated to miss not more than one meal. Examples would be cataracts, dental, therapeutic diagnostic procedures. For example, coronary angiography. Right? Today, if the patient is undergoing a CAG and unless he or she has to undergo a plasty, they would most likely be discharged the next day evening itself. And you do not anticipate them to have missed more than one meal. So these would be examples of minor procedures. There are no prerequisites for emergency life-saving procedures. However, for elective procedures, as I said earlier, reasonable glycemic control should be achieved. What is ideal is your fasting of 80 to 120, acceptable is less than 140. If it is more than 140 fasting, you would want to intensify the therapy. Postprandial similar ideal is less than 160, up to 180 is okay. More than 200 is when you intensify. And A1C, as I said earlier, ideal is less than 7. Less than 8 is still fine for these surgeries, and more than 9 is where you're going to be intensifying and taking action and not giving any clearance. What about the glycemic management in regard to the time of the surgery? For morning procedures, on the day of the procedure, take medications. Insulin and OADs at dinner. The previous day, you will continue that. Remaining nil by mouth till procedure is complete. So a lot of them will happen as minor procedures in the morning. And there is no real worry about it because patient is kept nil by mouth, but by about 11, 11:30, 12, the patient is allowed to eat. So they can very well just skip taking the medications on that morning, and post-procedure, the moment they are allowed, they can go ahead and start the day with their routine medications and follow that. So this will not hamper their control or cause any disruption or hypoglycemia. For patients who are not on insulin, those who are on OADs or GLP, all OADs and GLPs are continued as usual on the day prior to procedure, omitted on the morning of the practice. So essentially that day when you are NBM, but till the previous day you can give everything routinely. Restart the OADs and GLP once the patient resumes diet later that day. So no major worries in these procedures. Sometimes, because we would have read some earlier recommendations, as a rule somebody would have told you, patient admitted, stop all OHs. Well, you don't have to, because you stop all OHs, you're causing disruption for a minor procedure which is not needed. And unnecessarily by next day then the sugars are high, then you have to start insulin which may not be required otherwise. For patients who are not on insulin, again on OADs or GLP, patients with long-standing diabetes and those on more than 2 oral antidiabetic drugs are likely to deteriorate after drug discontinuation. So keep that in mind. Dysglycemia is likely with poor pre-procedural glycemic control. So if already the patient has come with high sugars, this may worsen. Should be treated with insulin infusion during the procedure and may require subcutaneous insulin for a period after that. So again, based on the pre-procedure sugar values, you will decide about the use of insulin. This is a busy slide. I would not have the time to go through all of these, so those who are interested can just take the pictures. Of course, they are all available on the RSSDI website from the guideline point of view. I'll take a minute or two more, sir, before I finish. So recommendations for perioperative insulin adjustment. So it's what we've done here is told you different situations, that what if the patient is on just basal insulin, what if the patient is on premix once a day, premix twice a day, very, very specific. And if I have to go through each of these examples, will actually take time. So which is why I'm saying that this is clearly pointed out. For example, a patient is taking a basal insulin, let's say glargine once a day in the morning or evening. The day prior to admission, you don't have to change the dose. If somebody was taking 15 units of glargine the previous night, you can still pretty much give that. In the morning of the surgery, no drug to be given at that time. Check the sugars 4 to 6 hourly. If it's a morning surgery, and similar for an afternoon surgery. So though we said it morning is preferred, very often it may go to afternoon because of logistic issues. Again, for non-insulin medication adjustments, well, so if it's acarbose, and I'll quickly run through these at least. If it's acarbose, previous day take as normal, omit morning dose if the patient is nil by mouth, and give morning dose if the patient is eating. So if the surgery is in the afternoon, and morning you are going to give, there always says light breakfast on the day of the surgery in the morning at 7 a.m. Half the times I find, and my surgical colleagues can pardon me here, is when the instructions are written, they don't even realize what is the practicality at the hospital. So they want to do a surgery at 10:30 in the morning, and they will say till 4 hours before, a light breakfast at 6 a.m. in the morning. A lot of hospitals will not have any provision to give any breakfast at 6 in the morning. So writing that only creates confusion. So you can always have a chat in your hospital that what do you really mean, and is there provision to supply this? So having said that, if the surgery is in the afternoon, you can give the drug in the morning if the patient is eating. For meglitinides, previous day take as normal, omit morning dose if nil by mouth. If the surgery is in the afternoon, same principle, patient is eating a mild breakfast, you can give that meglitide in the morning. Metformin, again, for the previous day, it can be given as normal on the day of the surgery. So this is a deviation from what was earlier. This is for minor surgeries. So you can very well give metformin today for minor surgeries not requiring general anesthesia, sedation, and so on. What about sulfonylureas? Previous day take as normal. For the day of the surgery, you may want to omit, again, depending on whether your sulfonylurea was given in the morning only or in the night, you will then decide. So if the surgery is morning or afternoon, skip the dose of sulfonylurea then. By evening, if the patient is eating, you will restart. If the patient is still on liquids and you're not sure about the intake, you can skip the sulfonylurea the whole day and then restart the next day. Again, understand these are situations for minor surgeries only. DPP-4 inhibitors can be pretty much given as normal, they won't impact, and GLP-1s omit on the day of surgery if they're on that. Insulin regimens, immediate post-operative period would be IV insulin protocols, especially for major surgeries, patients being observed in the ICU and so on. For patients on enteral feeding, you can have your basal bolus with some correction boluses going in. Similarly, for tube feeding, you will follow principles of using insulin. So wherever the oral intake is uncertain, better to be on basal bolus insulin. If the oral intake is absolutely nil and patient is on other aspects or critical or on inotropes and so on, then IV insulin is the preferred one. Evaluation for emergency surgery, pre-op assessment, and that's my last slide, and I would finish with this. So we are very often called to give physical fitness as physicians, fitness for surgery. And then they will ask for an anesthetist fitness, and they will also ask for a cardiac fitness at times. So, and your job, you will essentially go about and see the metabolic status. You're looking at the sugars and certain other vital parameters and critical reports, and the status of ketones where required. You'll check for the volume status, check for orthostatic hypotension, a good thing, especially for patients with diabetes of long standing. As busy as you may be, look for orthostatic hypotension. It tells a lot about possibility of cardiac autonomic neuropathy. This is more important from anesthetist point of view, who want to take all precautions and clearances in somebody who has severe autonomic neuropathy, because we know the chances there of things going wrong, including death on the table, is much higher in patients with long-standing diabetes and autonomic neuropathy. Preoperative treatment will delay surgery if possible until metabolic control and volume status are stabilized. Okay, this is where you are asked, as I said, very often. I don't know what the trend here is in Chennai and around. In Mumbai, the surgeons have become extremely dynamic. We very often get a call from the hospital RMO. Yesterday the patient was operated, today the sugar is high, the surgeon has given you a reference. So it's not what it used to be, right? So everybody is in a fast-phased mood, and people want to do that because the surgeon will say, yeah, today, you admit and I'll do the surgery today, right? And then we'll handle everything, don't worry. So that handle everything part comes on to you. Well, that's your job. So whenever you're called in, you will jump in and try and do your job at the earliest. But where possible, we spoke about it, the situations where you should delay surgery and where you shouldn't delay the surgery, and you may be good enough to call your colleague and say, look here, I think this patient is fine, the A1C was good, let's not worry about 1 day's fasting PP, which may be varying, and optimize blood glucose, electrolytes, and acid-base status depending on the nature of the surgery and patient's background condition. So with that, let me halt here and hand it back to the chairs for any question answers with all the speakers here. Right?